Hello, my name is Alan Priester, representing Avenda Health, and I'll be giving a talk on some of the emergent applications for cancer mapping with artificial intelligence. My talk is split into two topics, on the use of AI cancer mapping to predict extracapsular extension and tumor volume. Let's get right to it. For my first topic, I'll be discussing the assessment of extraprostatic extension using AI cancer mapping. The status of extraprostatic extension, or ECE, is critical for risk stratification and effective prostate cancer management. Current techniques for assessing ECE include MRI interpretation, clinical variables such as PSA, and predictive models such as Parton tables. Unfortunately, these methods are imperfect, and when mistakes are made, the repercussions can be severe. In the case shown here, ECE risk appeared low on MRI, but when nerve-sparing prostatectomy was performed, the patient had positive margins. So there's room for improvement, and our working hypothesis was that ECE prediction can be improved using an AI cancer mapping algorithm. To that end, 121 consecutively accrued cases were retrospectively analyzed. All men had MP-MRI, tract biopsy, and radical prostatectomy. Ground truth was established through analysis of whole mount histopathology, where a broad range of ECE locations were observed. See the red arrows on the accompanying images. For comparison, standard of care ECE predictions included a radiologist assessment of MRI. They estimated the capsular contact length of tumors and also assigned ECE risk using a 1 to 5 Likert score. These images illustrate low, medium, and high-risk cases. Other metrics included PSA and Parton table predictions. Meanwhile, AI predictions were made with FDA-cleared software Unfold AI, which used MRI, biopsy data, and PSA to generate 3D cancer estimation maps. Using these maps, ECE risk was estimated as the total cancer probability adjacent to the prostate capsule. For the earlier example case with positive margins, AI correctly determined ECE risk to be high in that region. Predictive accuracy was assessed using area under the curve measures and compared using DeLong's test. AI, shown in blue, had an AUC of 0.88, significantly outperforming PSA, Parton tables, Gleason grade group, and MRI Likert scores. AI also outperformed ROI capsular contact length, though the difference was not significant. In conclusion, AI was shown to accurately map cancer risk at the capsular boundary. Based on these cancer maps, AI performed significantly better than most conventional methods of ECE detection. With such an AI-based tool, clinicians could more precisely plan treatment, potentially improving outcomes and quality of life. For my second topic, now I'll discuss the estimation of tumor size using AI cancer mapping. The accurate estimation of tumor size is critical for assessing risk and selecting treatment strategies. Unfortunately, conventional clinical and imaging estimates are weakly correlated with tumor size. MRI in particular has been shown to systematically and sometimes severely underestimate the true size and extent of tumors, as seen in this image. So there's room for improvement, and we hypothesized that tumor size estimation can be improved with 3D artificial intelligence-based cancer mapping. 97 cases with at least one biopsy-confirmed and MRI-visible lesion were drawn from a radical prostatectomy dataset. A pathologist annotated whole mount slides to define ground truth cancer contours. Then, each slide was registered to preoperative MRI, and the cancer contours were interpolated in order to compute ground truth tumor volume. The FDA-cleared software Unfold AI used MRI, biopsy data, and PSA to generate a 3D cancer estimation map. Each voxel in the map is assigned an estimated cancer probability, so it was hypothesized that the sum of all voxels could be used to estimate total tumor volume. This novel metric was correlated to true tumor volume using linear regression. These images illustrate that hot cancer maps often indicated large, aggressive tumors, whereas cool cancer maps corresponded with smaller tumors. 6 conventional metrics commonly used to assess tumor burden were computed for comparison. They were PSA density, PI-RADS contour volume, number of positive biopsy cores, maximum cancer core length, and total cancer core length. All these metrics were likewise correlated to tumor volume, and the accuracy of linear regression fits were compared using Wilcoxon sign rank tests. Note the distinct lack of a linear trend for many of these metrics. AI cancer maps were strongly correlated to tumor volume, with an R-squared coefficient of 0.81. All conventional metrics were significantly less accurate than AI, with R-squared values ranging between 0.26 and 0.69. PSA and PI-RADS contours were particularly bad predictors, whereas biopsy-based metrics were moderately better. In summary, AI was highly predictive of tumor volume, outperforming conventional measures. This approach has the potential to improve risk assessment and treatment planning, particularly when defining margins for focal ablation or radiation. Armed with AI tools, clinicians may be able to deliver better treatment outcomes with fewer side effects. These are my references. Thank you very much for your time and attention.